Good morning. My name is Alexandra Lansky from Yale University, and it's my pleasure to be here this morning with Dr. Thomas Aversano from Johns Hopkins. You're going to tell us a little bit about the CPORT-E trial, so maybe you can give us some background to start.
Well, probably the best place to start is 10 years ago, when CPORT and other studies had shown that primary angioplasty could be done safely and effectively and was better than the current standard of therapy, which was lytic therapy, for STEMI patients at hospitals without on-site cardiac surgery. And over the years, that sort of engendered the development of a number of standalone primary angioplasty programs, which did nothing but primary angioplasty. And so we think that those centers are ones that are very beneficial to the community. They reduce mortality and the morbidity associated with STEMI, and probably provide more prompt access for care to the patients that come to their hospitals. But it's very difficult to sustain a standalone primary PCI program, both from a human resources point of view and from a financial point of view. So one of the primary, or I shouldn't use that word, but one of the major motivations for seeing if we could do elective angioplasty at hospitals without on-site cardiac surgery was to help sustain those programs. There's also some evidence in the literature from Crusade, for example, that at least in some locations there are patients who present with acute coronary syndrome should be transferred to a tertiary hospital for consideration of revascularization and don't get transferred. And in the one study that they did present, 11,000 patients with acute ACS that presented to hospitals that couldn't perform revascularization. About 40-something percent, 48% were actually transferred, and the majority were never transferred. And you could see the mortality difference was very significant if you got into a hospital that could do the revascularization versus couldn't.
Right.
So there was a question about whether it's really true that everyone has adequate access to even non-emergency angioplasty services. And then there was the need for research. So those were the kind of motivations and background for CPORT-E.
And can you tell us a little bit about the trial, how you set up the trial?
We had 60 centers, participating centers, all without on-site cardiac surgery. Those 60 centers had about 100,000 visits, cath lab visits. 75+% of those patients were consented for participation before they came into the cath lab for their diagnostic cath. 18,867 were finally randomized. About 2,200 patients, these are give or take a few numbers, but just under 11% of the patients were judged too high risk. So the protocol said no unprotected left main angioplasty, no angioplasty if your EF was less than 20%, no atherectomy catheters, no cutting balloons in de novo lesions. You could use them in stents, but not de novo for the obvious reasons. And so that excluded about 10% of the patients. But 90% ended up in the study and were randomized. The randomization was asymmetric. It was 3-to-1. For every 4 patients that got randomized, 3 stayed at the hospitals without on-site cardiac surgery, and 1 was sent to the tertiary facility. And that was to augment the volume of the no surgery on-site hospitals. The 2 primary endpoints, safety endpoint, which was mortality at 6 weeks, and then a so-called efficacy endpoint, which was the composite of death, myocardial infarction, and target vessel revascularization at 9 months. Non-inferiority trial design. And at the end of the study, both objectives, both primary endpoints were non-inferior at the hospitals without on-site cardiac surgery. We also looked, of course, at emergency surgery requirements, and out of more than 14,000 randomized patients at the no surgery on site hospitals, 10 needed emergency surgery, so a little less than 0.1%. At the hospitals with on-site cardiac surgery, 0.2%. Didn't quite reach statistical significance, but of extremely low need for emergency surgery.
And those patients were transferred to a tertiary care center?
Yeah. Now the transfer times were different. The time between the decision to leave the lab and arriving in the operating room We didn't use time to cardiopulmonary bypass because a significant number were done without cardiopulmonary bypass. But the time from decision to leave to the operating room was 56 minutes longer if you were off-site.
Right.
So it took that much more time.
So what are the implications in terms of, where procedures are going to be done going forward?
Well, I think it's important to note that we did not do this study to try to expand the number of angioplasty programs in the United States. This was a study that was really looking at whether you could divorce angioplasty and cardiac surgery. Is this another tool that healthcare regulators could use to decide how to appropriately geographically distribute this capability? And that's what we hope the study results will be used for.
Well, I want to thank you very much for your time and coming to join us today.
Thank you.
And that concludes our interview.